Hi, everybody, and welcome. I'm Dr. Scott Worden, the TOS guy, and I'm here today with Dr. Art Jenkins from New York City. Hi, Art. How are you?
Good, Scott. How are you doing today?
Great. Today, topic of our talk is Do I have TOS? Our subtitle is Helping Patients Understand the Symptoms of Thoracic Outlet Syndrome, their meaning, and the best thoracic outlet syndrome tests available today in 2022. So, Art, people ask, Do I have TOS? What would you say are the biggest points when you're talking to a patient, your history and your physical, that lean you more towards TOS and into further investigations?
Well, I mean, I think Tracy says it best is TOS is a disease of reaching. If you're having problems that are positional, if they are worse with your arms up, arms forward, if you're noticing that you have intermittent symptoms that initially, and that then gradually become more consistent, certainly it's something to consider. Obviously, it's a disease of the arms primarily. The thoracic outlet leads to the upper extremity. So it's not so primarily a syndrome of leg pain, sciatica, low back pain, but you can have pain anywhere in this region. And so these are the things to think about. Do I have arm pain? Does it go down my arm? And is it reproducible generally with the same types of reaching or other activity motions? Sometimes it's even sleeping in position. So these are the things to think about. Should I even consider TOS as part of or what's going on with me? Is it just old age? Is it just, I worked out too hard and, things like that? The answer is often no. But sometimes you just get arm pain. You slept on your arm funny, and it's not TOS. But other times it can be.
So you had mentioned intermittent symptoms that become constant over time.
The longer this goes on, the more severe the symptoms tend to get, and sometimes they go from being minor and bothersome to severe and disabling. And weakness comes from being positional and only some of the time to so severe that the muscle is damaged, and sometimes there's even loss of muscle. There's atrophy where the hand starts to disappear. It's a progressive condition, generally speaking.
Would you say, how long, can I ask you, how long have you been in practice?
A gentleman doesn't ask those types of questions, Scott, but
more than 20 it's like years. Asking a woman in an elevator how far along Correct. She is.
More than 20 years in practice, and another 10 to 12 years in training to get to that practice point. So the understanding both taking a clinical history as well as understanding the role of neurologic exam and neurologic testing, both radiologic and non-radiologic testing, is certainly something that we've been.
Would you say that in your time in training and practice that you've seen a change in either the attitude of docs, the willingness of docs to see this disease, or in patients seeing the disease?
So certainly in many ways it's kind of an orphan condition. It was earlier back in the 80s, it was really much better known and understood. And then there was a little bit of a backlash when a well-intentioned neurologist decided to label a subset of TOS as disputed TOS. In addition to that, there is some understandable frustration of treating difficult to treat patients, or even in many cases, difficult to diagnose and understand patients. And so I think for a while there was a significant step away from even many clinicians learning about TOS. So I would say TOS, as I said, has become kind of an orphan condition. I will say that there has been a lot more interest in it lately. Obviously, you've been able to generate a lot of interest and a lot of education around it. And you've also, in many ways, you've even been a little bit of a lightning rod in pulling people of like minds together to be able to talk. And so obviously, there's a number of us who are collaborating, and I have a number of people I work with in New York, but also it's nice to have a community, and in some cases it's nice to have a community center, so to speak, even if it is a virtual one, where we can discuss these concepts, and we are getting the word out more and more, and there are newer and newer treatments for it, and someday soon there'll be even better diagnostic tests and even better treatments than what we have now.
I think you've covered a whole lot of points there that are very, very interesting. It did have a stigma in around the year 1990 that was just unscientific. And while the vascular forms are widely recognized, I don't think anybody questions those. The neurogenic type has been hard to pin down. So I don't know if you'd call people skeptics because they refuse to admit it exists. There's a healthy skepticism, but there's also an unhealthy skepticism where you just want to ignore it. And then you brought up the fact that some of these patients are difficult. For all of our patients who are listening, this is not intended as a slight in any way. I think Art would agree that when patients have chronic pain, they get depressed, they get anxious, which makes the chronic pain worse. And we actually understand this now much better than we used to. So when I first started doing this, 20 plus years ago, TOS, we got a lot of patients that came to us because they had psychological problems. And it was my job to find something real and physical. So I've seen over that time, as you pointed out, better awareness, finding doctors like you and the other docs we work with around the country has been a pleasure because, not only are you super smart, but you're very anti-dogmatic. You'll ask those questions. You ask me and you ask other people the questions of why do you think this? What supports it? And if we can answer those questions, then we can handle the idea that maybe, okay, people don't all believe in this disease, although I don't think the disease cares whether we believe in it or not. We've also had successes with a lot of patients who have clearly, in my opinion, over the past 20, 25 years, come to us earlier, gotten diagnosed earlier and treated earlier, which is the next thing I want to ask you about. Have you seen an improvement in outcomes because we're treating patients earlier?
I think there's no question the earlier you treat any neurologic condition, the better you're going to do. In fact, actually, I often describe it as a graph, is that the earlier I intervene, the better chance I have of getting you back to a better place. That if you think of the disease being like a ball rolling down a hill, where the further down the hill, the more neurologic signs and problems you have. And so you start out close to the top of the hill and everything, the view is great from there. But as you go deeper down into the valley and more problems develop and more nerve damage occurs, what I can do to intervene, metaphorically, I often say, imagine I can get you halfway back up the hill. I can't always guarantee, sometimes you do, but I can't guarantee, I don't tell patients to expect perfection. Like life doesn't have to be perfect to be wonderful. And in many ways, what I can do is dependent upon where you are in the disease. And so I can, if I say metaphorically, I can get you about halfway back. Obviously, the further down the hill, the less of the hill I can get you back up. And so, when there's atrophy, it's a lot harder to recover from that. When there's pain that's gone on for over 2 years, we know that there's actually chronic brain shrinkage. There's cerebral atrophy in patients who have suffered chronic pain for more than 2 years. To me, it's the way I metaphorically describe it is, imagine your brain shrinks because it hurts so much that you don't even want to think that hard. But that's not quite the actual medical process by which these things occur. We don't always understand what those are, but metaphorically speaking, these are the things that I try to, and that's why it's important to intervene sooner rather than later, rather than, get kicked down the road. And the point we made about the difficulty that patients have and then some of the challenges they face. It's really depressing being told there's nothing wrong with you, that it's all in your head, that your diagnosis is disputed. And then that creates a nihilism and a lack of trust in the medical community. So this is, these are so challenging patients' problems. Not that the patients are the big challenge, but in some cases, getting patients help is the big challenge. And so,
So Wilborn, who you referred to, who said, I'm only going to accept true neurogenic TOS if the patients have muscle wasting and positive EMGs. This is exactly the opposite of what you're saying. If I
it's
wait that
basic.
long,
It's basically like saying, I only want to treat cardiac patients who have already had a major heart attack. And until they have a major heart attack and part of their heart muscle is dead, then it's
right?
not really heart disease. I mean, in this day and
Good
age,
analogy.
that would be malpractice. So
Or I only want to treat lung cancer patients once they have metastases to the brain and
right,
liver. Then I'll
exactly,
accept it.
exactly.
Right.
It's just misses the point.
And so that let a lot of doctors off the hook from studying the disease because it is a tough disease. The anatomy is complex. The diagnosis clinically is complex. And there is no absolute 100% test like there is for other diseases. So that allows a lot of people off the hook. Rather than studying it, they could say, well, it's disputed. I'll wait till there's proof, which to me is very logically, it's just a total failure of logic and rhetoric, I guess. You know the story because I probably told it before about the discovery of the bacteria that causes ulcers. And it was a doc in New Zealand that was sure that Helicobacter caused ulcers. And I was in medical school at the time, and we just knew that acid or the breakdown of the protective barrier caused ulcers. But he found this amazing thing that's so simple to treat, but it took him forever to convince other people to listen to him because people are people.
Yeah, and
Even
unfortunately, dogma gets traction
yeah,
very often. We believe.
especially when the dogma makes it easier. Oh, I can ignore this disease. That's easy. The other
Yeah,
pathway anti-dogma is I got to read all this stuff and I got to figure out this anatomy. So which choice is easier?
yeah, agreed. So,
So and for our patients listening, I know some of them have been through a few docs. I'll just tell you all who are listening, in my experience, which I guess I'm at the point in life where I can say in my experience and it actually means something because it's been enough years. Um, it's definitely better than it used to be. We saw lots of patients in the past who just saw 5 and 6 doctors. And as Dr. Jenkins said, they were just told, nah, nothing wrong with you, which
yeah,
made the disease worse and made these patients feel terrible. So,
yeah,
and another thing I've noticed is that I always bring up Major League Baseball pitchers and other athletes like Markel Fultz, #1 pick in the NBA draft. And, because ESPN is all over the place, someone gets a disease like that, they get a lot of media attention. I think that
sure.
educates patients at least to the name of the disease and then they can research it. So
Sure. Christopher Reeve
or-
brought an awful lot of attention to spinal cord injury.
it's great.
And Michael J. Fox brought an awful lot of attention to Parkinson research. And so very often it's good to have, while I would never wish anybody to suffer from any of these conditions, those who do and are able to share their experience in a meaningful way can really help a lot of people in ways that we don't always imagine.
Right. It has a positive benefit. The combination of social media and technology and celebrity is just huge nowadays. So these things that become viral can be very powerful.
Yep.
Yeah. Um, I've had a question in my mind which I've lost now, so I probably have to get diagnosed with early onset Parkinson's or something.
or
But
Alzheimer's.
yeah,
Or what's his name's disease?
what's what's his name's disease? That's terrible. I feel like that some days. And my wife, whose first language is not English, sometimes she gets distracted and she tries to tell me things like, Scott, you know that and she's waiting for me to answer her. And I've learned not to start guessing. Um, but it's interesting because I feel like that some days myself, I get too many distractions. So I want to remind people that the topic of this talk is about helping patients to understand the symptoms of thoracic outlet syndrome, what they mean, how they're caused, and what we think our best tests are available now. So I'm going to go back a step. You had talked about listening to a patient's story and some unique parts of the history that we will really lean us towards TOS. On physical examination, you do more than just a standard neurologic examination. Is that correct?
Sure. But in many ways, I think all of this, really, I mean, and this is in many ways, it's a lost art when so many clinicians these days are tasked with, they've got 12 to 20 patients that they have to see in an hour, and their administrators are driving them to hit their RVU targets, resource value unit. It's a measure of the amount of effort you've put into managing the patient. And so many doctors nowadays are driven by the corporatization of the practice of medicine.
Well, the
Even
RVU is also how they bill.
and exactly, but the point, and they have targets that they have to meet, and they're being booked for a certain number of patients, so that they frequently don't have the time to listen to the patient and listen and understand what's going on with them, and take that time. So it is important for us to try to, as clinicians, to try to drill down maybe a couple of key questions that we can try to teach our colleagues to if they hear an answer in this realm, to dive a little deeper, but also for patients to understand, to be heard, and to not take no or be brushed off because you've only got 1 minute left, and they've got to go through your med renewals, and they have to do what's called a med reconciliation, because they get a checkbox when they do that. That if you haven't been heard about what your condition is, it's your right to be heard. But also, it helps if you can be concise when you have that time with your clinician. However much time your clinician's giving you, you want to make the most of it. So understanding what the symptoms are and the things that we think about. So when you think about your condition and you think about what it is that's bothering you, you want to think, well, what makes it worse and what makes it better? How bad does it get? I mean, we're clinicians, but we're also humans and Americans, and we like scores. And so we talk about a score of 0 to 10 of how bad your pain is. Nobody wants to hear your pain is an 11 on a scale of 1 to 10, or a 12. And I get that all the time. It's a 20. No, it's a 1 to 10 scale, where a 10 is a broken leg, childbirth, something really severe. They want to know, how does that compare to that? And is it better or worse at different times? So, what makes it better? What makes it worse? In particular, then you want to think about what I like to think of are the three main flavors of neurologic problems. There's pain, there's sensation, and there's motor function, your muscles' ability to work and function normally. There's also coordination, but that's much more involved with higher level problems. With TOS, if you're having problems, it's primarily going to be one of those three issues, at least with the NTOS, neurogenic TOS. With vascular, you're talking about the ATOS and the VTOS. We're talking about changes in circulation, and similarly, you will get pain. But you'll also get swelling, or you may get changing color in your hand. And these are things that, if you're having them, you want to know them. And then the most important thing that you, as your patient, as being your own advocate, can do when you walk into your doctor's office, have a list. Make sure you've thought about this. You've answered, you've got a very brief synopsis of what's bothering you, what's going on, what you've done to make it better, whether it's medications, position, chiropractic, whatever you're doing that's working, and whatever it is that you're doing that's making it worse. Go in there with a succinct list that you can kind of bullet point to your doctor, so that you can get their attention, and they can then focus from getting a relevant clinical history to then doing the neurologic exam. That would be the next phase of the examination and of the evaluation. So these are the types of things that you, as you speaking to the viewers, obviously not to you, Scott, because you already understand this, but you as the viewer understand, I need to make the most of whatever time I have with whoever's going to be my first stop on the process. I want to get the most out of that. So then let's say,
great points. I would just bring up that a lot of our viewers and a lot of patients I've interacted with, and I'm sure you as well, have really learned how to advocate for themselves. They get on Dr. Google, they read a lot of stuff, and while they're not required to become doctors, some of them really surprised me with how much they've gained about this.
Right.
And, and what you're reinforcing is really valuable. Respect your doctor because he or she may have an ego left, even though things are challenging recently, but
Yeah.
try to form that alliance and work with them. I think that's what Art's saying. I just
Correct.
reinforcing it.
Correct. And to that point, you want them on your side. So you don't want to go browbeat them with your symptoms. If you lay the case out in front of them, they will happily take up the banner. And to be fair, sometimes you also have to realize if it's a lost cause, then maybe you need to
Right.
find somebody else or go
Right.
see somebody else. If somebody's not taking you and doesn't have a good explanation for you as to why you're going through what you're going through that makes sense and has a plan for helping you feel better, find somebody else.
Don't let them give you the old, it can't be TOS because there is no such thing. Don't
or
let them do that
your
to you.
EMGs are negative, or just, oh, that's not a thing, or that's not what you have.
Or rolling their eyes. That's always a bad sign.
Or not listening at all.
Right. So you were talking now about you were going to shift into physical exam.
Correct. So the first part of physical exam is looking at the person. So, we'll be looking at, well, what's the posture? How do they carry themselves? How do they walk? God forbid there's an actual other underlying neurologic problem that needs to be taken a higher priority. If you walk with if you're very unsteady on your feet, there may be either more than TOS involved, or it may not even be TOS. It may be one of the other neurologic syndromes that overlap with some of the same symptoms as TOS. Cervical myelopathy, other brain problems. There are a lot of things that on first blush sound like TOS, but aren't. So, so a general, how do they look? How do they carry themselves? How do they walk? How do their hands and arms work in general? Then we get down to the little bit more of the nitty gritty. What's the strength of all the different muscles, not just in the arms, but in the legs as well. For example, let's say somebody's got weak hands and that's what they notice. And you discover they also have weak legs. And then maybe once again, this is more of a global or larger problem than just the arms. And TOS may be either a red herring or just a similar finding. On the other hand, when there is thoracic outlet syndrome and TOS, there are pain at certain pressure points in and around the thoracic outlet, and in the region of what's known as the brachial plexus, or the major crisscrossing of the nerves as they leave the spinal cord and go out to the arm. And so, finding all those key pressure points, looking at the strength of the hand, and in particular, the strength of the hand when the arms are up and the arms are down, and looking for an asymmetry. What's interesting, what I find anecdotally, is that most patients are actually normal patients who don't have TOS or don't have TOS in that arm. They often are slightly even stronger with their arm up than arm down. But patients with TOS are usually more than 10% weaker with their arm up than with their arm down, just in gripping with their hand.
So you measure grip strength.
So we measure grip strength with just a cheap little digital strength meter that you can get online. Super cheap. It's so cheap. I have them in all of my office rooms in my New York office, and it's easier just to have them around so everybody gets tested. And then on top of that, we want to look for, is there any sensory disruption? So we check all what are called dermatomes, or the surface representation of individual nerves. And so we're looking at differences between nerve root, dermatomes and coverage, and individual peripheral nerves, because where things show up in the terms of where's the numbness, where's the weakness, where's the pain. There may be overlap, but there are also many times there are very specific and localized findings that help tailor the exam even further. And then,
So I'm going to interrupt you for a second here because this is a point I think you can really help patients. What's the difference between, for example, a C5 radiculopathy and a median nerve neuropathy?
well, so median nerve is probably one of the more common problems that people have, especially in this day and age. Everybody's on their computer; they're all typing away. It's and carpal tunnel syndrome, which is compression of the median nerve where it goes through the carpal tunnel in the wrist. It's endemic in today's modern society. And that is because it's a median nerve and typically a distal, meaning down towards the end of the arm, median nerve. It tends to be much more involving this part of the hand and the fingers, as opposed to classic TOS is actually more of ulnar and C8 overlap distribution because of where in the trunk that the thoracic outlet compression occurs. So you get a very different sensory distribution, different distribution of where the pain involves. Having said that, a lot of people's nerve dermatomes can be slightly different from each other, but this is where it's good to have the physical exam. And then little things like, physical exam, there are compression tests, there are other manual tests that we can do to look at, is a nerve particularly sensitive? And so whether it's called Tinel's sign, which is where you tap right on the nerve where it's potentially compressed, other forms of manual compression, checking for reflexes or loss of reflexes. There are, and then there's just physically feeling like, have they lost muscle here? Are they wasting in between their fingers? Do they have wasting in any of the other muscles in their arm or elsewhere? Do they have palpably tight cords in certain places that are characteristic for being a cause of impingement? So these are all things that a skilled, practiced, and trained doctor who's looking for positive or negative features of this diagnosis. If somebody, I've often said, seeing is believing, but believing is necessary for seeing. And if you don't believe in a diagnosis, you won't see it. It'll be right in front of you and you won't notice it. It's the old, you can't see the forest for the trees. And so you have to know to look for it, but hopefully that's been triggered by the well-curated story and history.
So for our viewers, if you see your doc and your doc does a standard neurologic exam, if your doc doesn't do these provocative tests, of which Dr. Jenkins has described several, then they either may not believe TOS is real. They may just not have experience with TOS. A lot of docs out there, I'm sure you find this, Art, too, that
A lot.
we find some docs who know a lot about TOS and other docs who just, through no malfeasance, we're busy people, they just have never gotten to studying it, and it's not an easy disease.
No, it's not. And especially neurologic problems scare some people off because they don't want to be wrong, but they also may not understand the consequences of being right or what to do, what the next step should be. Although in this day and age, with, as you said, Dr. Google on your consult list, it's not hard to figure out what the next steps could be. You need to find someone who's going to actually listen, investigate, care, and then send you on to the next step.
You brought up your skill set after many years of training reminds me in medical school when I first did a neurology rotation, our attending, after we'd see a patient, would make us guess what we were going to see on the MRI or the head CT. It becomes easy for people to just go look at the imaging, but what Dr. Jenkins has described is how to think where the lesion is coming. If it's in the brainstem or if it's a peripheral nerve out distally, it's a different examination. And there's a lot of logic to this examination that's fascinating, but you have to be looking for it. There's a bazillion tests you could do, and your doc needs to know the right ones. So
yeah, it's funny. There are a number of people in my profession as a neurosurgeon, as a spine surgeon, who really will look at the films before they even decide if they're going to take the patient into their practice and see them in their office. I don't do that. In fact, I often don't like to look at the films until I know what the problem is, because 40% of people walking around with no back pain at all have something that that's identifiable on an MRI. And so if abnormal findings are so common that 40% of people with no symptoms have them, it's
Right.
not, it's
So
much
if
more
you just look
important.
at the films, how much surgery are we going to do?
Well, and how much needless surgery,
Yes.
and so it's much more. I mean, I got to tell you, I can tell you story after story of patients who have come to me, in some cases already scheduled for surgery, and sadly, in many cases, who've already had surgery that didn't make them any better, and somebody didn't ask the right question and go down the right pathway. They saw something that had been done, and some imaging study, and said, oh, well, I see something I can fix, even if it's not directly linked to why the patient saw them in the first place. So it's easy to get distracted if you're not focusing on treating and making the patient better, not just their films.
And this is why when I talk to patients, and many of you out there may have talked with me directly, I don't say, come on in and get my scan. I'll say something like, see an expert like Dr. Newkirk, Dr. Jenkins, Dr. Hagen in St. Louis. See these people first and let them decide whether you need a scan or not. And for me, it's fascinating that there are TOS specialists, some highly published people and prominent names around the country that won't do imaging. I think of all the unnecessary imaging that's done. This is in the radiology literature as well. And then I think about the docs who say, you might have this complex disease, TOS. I'm just going to go in there. I don't want to know ahead of time. And that intrigues me. It frustrates me. But the imaging I do, as much as I believe in what I do, I still think it needs to be combined with someone who's a good clinical judge like you. So, I bugged you on patients, and, I bug many of my clinicians on patients. What did you see? What do you think? Will they go to surgery? Or if you've gone to surgery, did it match up with what we've seen? So for the visitors, if you think you have TOS and you get a test, if it's an imaging test, get mine. I firmly believe in it, but the test shouldn't stand by itself. It needs to be used properly, just as Dr. Jenkins is describing, with all these spine MRIs that are running around that look abnormal and don't mean anything. My soapbox. I'm going to get down from my soapbox for a second now. I have so many little soapboxes. So for the patient's point of view, you want a doc who you know is experienced in TOS. And it's a fair question to ask. Hey, doc, look, if you don't know much about TOS, nothing personal. I know it's a tough disease. That's a tough conversation to have with your doc, but it's your pain. It's your health, which you're deserved. You deserve good health if you can get it, right? So you need to advocate for yourself in that way too. As Dr. J suggested before, you want to form a partnership with your doc. If you go on Google, that's great. Okay. There's a ton of information. Again, I'm going to bring up something that I always bring up with Art, which is social media. There are places to go to hear about sources, but social media shouldn't be your source for medical knowledge. I know Art agrees with this.
There's no peer review on the internet, no peer review on social media.
You can say whatever you want. And the only difference is a moderator might wipe you out because they disagree. And the moderator doesn't usually have an MD degree. So Be careful. Use that to help find your sources, but then find reliable sources. And that extends to seeing an MD, whether it be a neurosurgeon, spine surgeon, neurologist, pain doc, whatever. It's fair to ask for everybody, are you experienced in TOS? I want to feel comfortable with you. And that you should assure yourself of. One part of what we do with a lot of people is we just get them to speak to docs who do have experience. Now look, Art agrees with a lot and disagrees with some, with people like Dr. Newkirk or, all these docs around the country refer people to. So another thing you might do if you think you have TOS is see more than one doc. I don't think, Art's ego would be hurt if, you've seen a second doc before you come to see him. Right?
Yeah.
And you know what? And I think as Dr. Jenkins is really sharp, I'll tell everybody that. But he could be wrong about something as difficult as this disease. So if it turns out you've gotten other opinions and it turns you go a different direction, Art's going to say, "Good, I'm glad you got better." Um, and I think that's the kind of doc that's really healthy to work with for all our patients. So we've talked about history a bit. We've talked about a physical exam requiring special expertise and provocative tests. What about what tests should a patient want to get if they have possible TOS?
Well, I think it'll depend a little bit upon what their symptoms are. If they are, if it's primarily pain, then you certainly MRI is certainly a first choice for most of these patients. Um, there are other tests. There's EMGs are primarily useful when there's already weakness or a significant permanent sensory deficit, meaning you've got numbness that never goes away. You got weakness that doesn't go away. The problem with EMGs is that most of the time, if you're intermittently weak, it doesn't show up very well on EMG. And to a certain extent, although some of my neurology colleagues who do EMGs will argue with this point, EMGs are somewhat open to the interpretation of the person performing them. It's not like, we run a blood test and you have a blood count and it's, 39,000 red cells. Then you run that same test on 15 machines, you get the same answer. It's very much open to the interpretation of the skill and the practice of the person who performed it. Because very often it's a technician who does it. Sometimes it's the neurologist themselves doing it. Sometimes they have a technician performing it. And so there may be two people involved in that process. So it's very open to interpretation. But what I have found for most of my patients is that if it's not a permanent problem, it doesn't show up, or if at all, or is being very significantly noticed on an EMG. So that's a late study, not an early study. There are others. There are some patients who literally can't get to one of your MRI places, although you are in more places now, so it's a lot easier. And I think actually we have a patient we're going to be sending you now that your MRIs are available in Florida. And Florida is close to many of the other, some of my patients from other parts of the South, a lot closer than New York is, or the left coast. And so there are other studies and sometimes it's actually helpful to get like a CT angiogram. It's a different test. It involves radiation. It's an X-ray type study rather than a magnetic wave study. And so it's generally not going to be my first choice for ordering tests. And sometimes I'll get both. Sometimes I'll get
Right.
both your MRI and a CT angiogram if I really feel that the bony anatomy is there's something about that really requires millimeter level precision. So, like for example, bone healing or fracture it may be easier to demonstrate. Someone skilled as Scott can tell, but somebody like me who's not a radiologist, sometimes it's easier to see the bone and the microanatomy on a CT than on an MRI.
Well, one of the papers you published used CT angiogram and 3D reconstructions to
Right.
show very nicely the anatomy and the relationships.
But anyway, so you want to get some study that looks at these types of things so that the clinician can tell what is the degree of compression, because ultimately the goal is not just to say, hey, you've got TOS, sucks to be you. It's you've got TOS. Here's
Where
what
do we
we
go?
do. Right? It's not about a pity party. It's about next steps. And so we have to have what the next steps are. And in TOS, it's usually getting the pressure off of an NTOS, it's off the nerves, and in VTOS or ATOS, it's off the vessels. And so how do we, do that? Well, we need to know where the compression is occurring to determine what's the most appropriate approach and what's the most appropriate treatment. It's a totally different entity if you've got a cervical rib than if you've got costoclavicular compression versus if you've got a pec minor syndrome and just a pec minor syndrome, or if you've got scalene compression from hypertrophy of your middle and anterior scalene muscles. I mean, these are all, or if you've got a fracture of a chronic fracture of either your first rib or of your clavicle. I mean, these are all different things that can result, and the way you treat that depends on where the compression is, how the compression looks, and how responsive has it been to other things short of surgery that have been done to try to improve you.
So that's a great discussion of imaging along with other tests. EMG, as you said, is a late test, and we want to treat people early. So we don't want to wait for a negative one. I think you've probably had colleagues who say, well, the EMG is negative, so it's not TOS, and that just delays the true diagnosis. So I think that lack of sensitivity of EMG, that it doesn't pick up cases early, has a couple of pitfalls. I, to all our viewers, would not let someone tell me your EMG is negative. Don't worry, it's not TOS. That statement is false. Just to reinforce that. Okay, EMG is frequently negative in patients with TOS, and especially in early TOS. We just have intermittent sensory symptoms and no motor weakness. That's when you want to be treated, or that's when you want to have the disease ruled in or ruled out. Imaging-wise, CT angiogram is certainly helpful in a lot of cases. It shows bony anatomy in great detail, better resolution than MRI. It takes a while to learn how to see the bones on MRI. CT angiogram shows the blood vessels great and the bones great. The soft tissues not so much, but it has tremendous value in certain cases. MRI shows soft tissues beautifully, in my opinion. Obviously, I'm biased. I think it's the best test. My bias is based on many years' experience as a radiologist and working with the disease, so I think it's a valid bias. Ultrasound can be helpful in certain cases, but it's limited. I always tell this, that Adson, who first came up with Adson's test, where you measure the patient's radial pulse at their wrist and you manipulate their arm and their breathing and their neck. That was what Adson had in the 1920s. Some people today are still doing essentially an ultrasound Adson's test. They'll measure the blood flow out here after the vessels pass the collarbone, but it can't show you the space between the collarbone and the rib. It's useless there. And we don't really care whether the blood vessels are compressed in neurogenic TOS nearly as much, because the vessels can be compressed without nerve compression, and the nerves can be compressed without blood vessel compression. So ultrasound has some value, but in selected situations. Again, I'll reinforce that the imaging should be interpreted by a good radiologist who's experienced, but that report, that data, is something that the clinician uses along with everything else. Okay. And I had trained in internal medicine first a long time ago, and I would always talk to my interns when I was training them, and it had been taught to me. When you get your chest x-ray, when you get your ultrasound, when you get your results from an MRI, look at them after you look at the patient. Right, Art? That's just what you said before. We're just reinforcing it. And I'll say one more thing about this. TOS is clearly a team doctor sport, okay? If it were low-hanging fruit, we wouldn't be having this channel. We wouldn't be finding patients like you, difficulty in diagnosis, right? It's not a low-hanging fruit. It requires a team. And as Dr. Jenkins said, there are many forms of it, many anatomic abnormalities in there that could be present, and they can be treated differently. So you want a good doc working together as part of a good team. That's been, for me personally, for all our viewers, part of the professional enjoyment I get out of this is I've met incredible people like Dr. Jenkins, who's whip smart, and we have questions together. We try to figure stuff out, and we've made progress. So you want to be with a team of docs. That's another step you want if you think you have TOS. Okay, another little soapbox. I'm off now. I'm getting my feet clean at least.
Well, I think it's worth mentioning, though, that, we don't, nobody should at least treat patients in a vacuum. I mean, we're all part of a team. And in terms of developing the process and, somebody with the first diagnosis of TOS doesn't go to surgery the next day. You want to make sure that they've done all the things that are necessary. And if you have a team of people that you can work with who will help you to make sure that, and my philosophy has always been if everybody has the same knowledge, whomever sees a patient, doesn't matter who sees them first, they should get the same treatment the whole way down the line based upon what the right thing to do is, not just, well, I'm going to treat you in my silo until you run out of benefits or until I've done X, Y, and Z. And then and only then will I let my patient leave. You're not my patient. You are a patient I treat. I don't own my patients. My patients come to me to get the best care I can provide. And when it's the best care that needs to be provided isn't from me, I send them to that, whoever that is. And that's the kind of team you want to work with.
And another thing that's often helpful for our viewers to have one quarterback, whether it's your primary care doc or a super specialist like Dr. Jenkins. You want somebody to kind of have access to all the tests and all the specialists so they can put it all together. So make sure you kind of pick one doc who's knowledgeable about TOS, who can have access to all your data. That's another little piece of advice I give.
And keep them in that loop. Don't
keeping the loop.
Make sure that if you're going out to, be treated elsewhere, feed back to them and check back with them. If that's who you want to be your quarterback, you want the quarterback to know what the plays that are being called are, not just, show up and say, all right, what are we doing now?
Right. Again, I'm going to reinforce that this topic is about, do I have TOS? But it's also helping all of you understand the symptoms of TOS, what the symptoms mean, what their causes are, and how you can get the best currently available tests and diagnosis in 2022. At this point, unless you want to add something else that I'm not bringing up, Art, I'm going to see if we have some questions from people, if you'll be willing to answer them.
I'm fine. No, I think we certainly have given people an idea of what to look for in themselves, what to expect, and what to convey to a physician or to a physical therapist or whomever it is that's going to be your first foray into making this diagnosis. And then, and take notes. Just, it's a process. Life is an iterative process. We do things over and over, and each step we try to improve our process a little bit. It's not, we don't have magic wands. Every day we try to make it a little bit better.
And advocate for yourself. You're the patient, but you know what? With Dr. Google, along with people who are experts, you're in charge. You can help take care of yourself and make sure that the right questions are asked and answered. I'm going to remind people, please subscribe if you haven't already. That helps us. And please hit the like button. That really helps get the algorithm going and helps other people find us on YouTube and our other social media. Our social media is TOS MRI. You can find us on Twitter, YouTube, as you know now, Facebook, LinkedIn. You can reach out to me and my staff through the website, tosmri.com. Go to the last menu on the right and you'll see contact us. And we talk with a lot of people this way. We're always glad to steer you to experts. We're glad to answer questions about TOS or about our NeoVista MRI. Right? Hit the like button. Good. Herb, you want to start queuing us up with questions, good questions that we have. All right. Christoph, hi. I just want to thank you for the event. Thank you. And congratulate Dr. Worden for entering a TOS team in Florida. Thank you. I'm actually the director of imaging for the Advanced Robotic Surgery Center with Dr. Gargoslu in Florida, another guy who thinks out of the box. And it's an honor. And we're writing some papers already and trying to make progress in this disease, help people. Thank you. Tim Bitts. Many physical diseases such as beriberi, pellagra, scurvy, and rickets are known to be deficiencies of various degrees of vitamin B1, B3, C, and D3. Even as TOS is physical pinching of the nerve bundles, can TOS also be due to nutritional deficiencies as well as mechanical? That's a very interesting question we haven't been asked before. So the first thing I'm going to punt it to you, Art.
So I would just say right now we haven't identified any specific nutritional deficiencies that are tied directly to TOS. We do know that certainly VTOS does relate to difficulties people have with clotting and other things like that. And so there are some nutritional circumstances, vitamin K deficiency, and things like that that affect people's ability to clot or result in bleeding. And so I would say that I would never say anything is absolutely and never. But right now, we don't have any identified syndromes of nutritional deficiencies. But certainly, if there's a particular consideration that you have that you think might be related, or if you've seen patients that you've treated with nutritional supplements that have resulted in dramatic improvement, please let us know. I'm always on the lookout for anything that's going to help my patients.
So it's a great question because there are peripheral neuropathies associated with these diseases. But as you had described before, as you get the pattern of the neuropathy, it's going to tend not to be what we know now as kind of a classic. It could be throughout the body. And I think it's a correct assumption by me that longer nerves, like to the lower extremities, tend to be affected more in these metabolic diseases because there's more surface area to be damaged or more volume.
Yeah. No, and it's not to take away the fact that those are valid and significant neurologic conditions. They're just right now we don't have a direct connection between them and TOS. And this is a TOS talk.
Part of the reason the question is interesting is because we do have other associations that are not proven but suspected. For example, hyperflexible people with Ehlers-Danlos syndrome. Also people with venous congestion where the blood flow doesn't drain from the arms so easily. There's some evidence for both of these things. So not the obvious that it's just mechanical compression.
And other vascular circumstances that may significantly exacerbate thoracic outlet symptoms. So there is an awful lot more out there than is described in the textbooks. Otherwise, we wouldn't need to update textbooks every so often. We wouldn't need an internet if the amount of information that we had wasn't constantly expanding as we learn new things. So that's why I never say absolutely not, because I would never insult somebody else's intelligence who's working on their own project and say it can't be so. I'm prepared to listen. If you've got a good hypothesis and some good evidence, teach me.
Thank you. That's a great question. Appreciate it. Herb, who's up next? Okay, so Herb is asking our moderator.
I see a couple of comments oh, here we go.
Okay, Beverly says, can trigger finger in multiple fingers develop after months of untreated TOS? Do you treat trigger finger much?
Well, I don't treat the trigger finger per se. There are a number of hand and other specialized orthopedists who treat those types of conditions. If the problem is from underlying or untreated TOS, we would treat that. But typically a trigger finger is much more of a contraction, and that would have to separately be released. Could it develop from it? I can imagine that it could. Any particular case, did it develop from that? Well, that's where the details matter and the radiologic workup. So could something like that happen? It could. We do know that the muscles involved can result in significant weakness, pain. And in fact, actually, some patients develop used to be called causalgia. Now it's called complex regional pain syndrome. And that can result in patients having very severe pain. So
there's also patients who get very severe damage of like an ulnar nerve and get a claw hand, but it's a clinically distinct thing from trigger fingers. So correct. I'm not aware either of an association between chronic TOS and trigger finger, but if your doc isn't sure it's trigger finger, there are diseases when you allow TOS to go long enough that the hand muscles atrophy and the position of the fingers does change. We tend to see these in medical articles from decades ago. I don't think TOS is really being ignored for that long anymore. So if it's really bad TOS, I think most docs can find it.
I would say, that's a good question, but that's if there's a specific patient question, I would go back to a specific examination and have your doctor actually evaluate that.
Art, can you hear me?
I can hear you. You seem to have vanished.
Yeah, something with my camera.
Let me into the metaverse directly.
Let me go back to my software and see what's happening here.
So there are a couple of other questions I see that have come up. Yep. And so the list of specialized questions was a prior one. I think we talked about them. Physical exam that targets the thoracic outlet symptoms, and then and a good MRI. Welcome back, Scott.
All right, let me hook up my
You're
phone
back
into it. It's weird. I got some kind of marketing video that started playing by itself for some video game. I don't know what it is, but there's always clever people out there trying to get your attention, right?
Yep.
All right, good. So we're back. So let's see where we are with questions. Sue Hogg. Do TOS and rheumatoid arthritis have similar symptoms? I have RA and I have TOS symptoms.
Well, I think RA is a global syndromic problem that affects multiple joints from the cervical spine all the way down to the individual joints of the fingers. And so if any of those joints in between are causing compression on any of the neurologic structures, you can have TOS from that. But it's also very possible that you're getting the arthritic degeneration in the elbow that's compressing the ulnar nerve, in the wrist causing a compression on the median nerve, other places in the body pinching any other nerve. So you might have TOS symptoms, and you might actually have TOS that's derived from the RA. In that particular case, first and foremost is you got to get the RA under the best possible pharmacologic control that you can. And then after that, focus on treating the consequences of the RA. So
as radiologists, we'll see RA in its active phase, but we also see chronic degenerative joint disease in somewhat unusual locations when the disease is long and progressed. So even after it's treated, as Art is stating, we get residual degenerative changes, which means the bone forms spurs near joints. It enlarges and forms unusual configurations, which can press on the nerves that go by. Also, you're probably on chronic steroids, and there's some immune suppressants that are used for RA. I'd have to go back and review. It's way beyond my field, but maybe some of those could be causing a metabolic neuropathy. So it's possible you could have a multifocal peripheral neuropathy. This is something that, probably a doc, a musculoskeletal doc or a rheumatologist is much more familiar with to know if any of the medications are at risk for creating a neuropathy. But I'm not familiar, and I haven't seen a patient with RA at the same time as TOS. So I don't think they're similar, my experience. So we're having an issue with people submitting questions due to Facebook. We're not connected properly, but we're going to look at some of the comments here, which we have. Oh, there we go. Another one coming through. Great. So John from St. Croix says, my symptoms didn't begin until I fell in the kitchen and landed on both hands. Could that have caused my TOS?
Yeah, that sounds like a very, very common, chief complaint. We in the medical profession, we speak a lingo, and you start off with the chief complaint, the bullet point, what's happened, and then you get into the HPI, the history of your present illness. How'd you get there? And so very often the chief complaint is I have these TOS symptoms, and then the first line of the HPI was asymptomatic until something happened. And sometimes I've had patients say have an air conditioner unit fell on their shoulder, or they fell down. Falling down on your hands is actually a very common initial way that the aggravation happens. Now, there may be some underlying aspect of your medical or just physiological status that might have predisposed you to it. For example, maybe there was another injury earlier. Maybe you have this hyperflexibility that we were alluding to. Maybe there are other things, and sometimes we put it all together. We realize, hey, maybe this was going to happen anyway, and this is what triggered it. Or other times, it's literally they were totally fine. They fell, and boom, that injury damaged the muscles in a way that that has left you where you are now. The reason I say it like that is that many of the times that and Scott's heard me talk about this, is that the scapula drives the clavicle. The clavicle is kind of like the stick shift. Okay, the scapula is the wing in the back of the shoulder that actually the arm sits in the glenoid fossa, which is part of the scapula, which is it's got a socket, and then it's got a big wing that attaches through a separate bone called the clavicle, the collarbone, to the chest. And the 17 muscles that support and surround the scapula drives the clavicle. And there are very few muscles that actually attach to the clavicle. It's all being driven by the scapula. So it's very often an injury to the support of your shoulder blade that results in this injury that results in symptoms of TOS. And so, yeah, that's a very common presentation.
That brings up a point, Art. First of all, the description of the scapula is great. It just floats, and it can go anywhere. Secondly, one thing we didn't discuss, my mistake, is that simple thing. What are the events that we commonly see causing TOS? If our patient wants to know if they have TOS, what kind of history could they have?
Sorry, would you ask that again? Sure. I got distracted.
What are the common histories?
Questions popped up.
Yeah, what are the common histories we hear from patients? The topic of our talk is, could I have TOS? We didn't even talk about what's the chief complaint. What do patients often note that is the thing that started their TOS, either gradual or sudden?
Yeah, well, pain with moving the arm. Pitchers get this,
like car wrecks, right?
Car accidents. But it's primarily something wrong with the arms and or the immediate neck area. And so it's, there are plenty of people who've had car accidents and walked away from them. They've been very lucky. And there are other people who have had sometimes even minor, somebody may have told you it was a minor car accident. That shouldn't be bothering you. But if there was some other underlying issue that may have predisposed you to this, it's not minor to you. It's yours. These are your symptoms, and they need to be taken seriously.
Some sports, overhead sports we talk about, basketball, tennis, swimming, rock climbing. Some people have, very sudden falls, and they have to grab onto with their hand, they drop their body weight onto one arm.
Right.
And then the patients who have chronic causes, computer use, which you already mentioned. Everybody's in a bad position, myself included.
It's the reaching. It's, it's putting things away in the
your head down in a laptop.
Or putting things away in the cabinet up above. Everybody's got those dish cabinets that are up high, and you start noticing that you're getting stuff going on up there that you didn't have when you're, just doing things at the kitchen counter.
Things that you do in an awkward position. I've seen several UPS drivers with TOS, for example. Their work environment is kind of challenging in those trucks. Okay. I'm going to go on to the next question, Herb. Hi, Anna. How do you confirm the difference between a dorsal scapular nerve entrapment and NTOS with considerable neck and scapular pain is involved? That's a cool question.
Well, I think a really good exam, and actually palpating along the distribution of the dorsal scapular nerve, versus identifying, is this an entrapment more in the thoracic outlet region. Dorsal scapular nerve is more or less an end branch off of I think it's off the axillary nerve, right, Scott? Or is it which the
Yep.
yeah?
The
So
dorsal
you're
scapular
really
nerve comes.
looking at a distant, small nerve that has a very focused location and distribution. So it's pretty easy with a good exam to feel along there and trigger it. Don't trigger it. You're not going to have symptoms down into the ulnar nerve from a dorsal scapular nerve entrapment. It doesn't mean, though, that you couldn't have a dorsal scapular nerve entrapment and have it cause a weakness of part of the parascapular support. And then that can cause other problems. So sometimes true related, and sometimes it's true not related.
That's a great point. The balance of these muscles here, as you mentioned, there's 17 muscles, and there can be all kinds of imbalances, tension or laxity or a neuropathy causing a weakness of one. And if your shoulder girdle starts dropping, it's going to drag the collarbone down against the first rib. So that's a great point of yours. I would add on that one of the confusing things about TOS clinically is that so many different territories are involved. It's not a single C5 nerve root. Dr. Jenkins mentioned you can do a study of dermatome. You can find weakness of the muscles that respond to C5 or C7 or whatever. But when you have multiple nerve roots involved, or even partial involvement of multiple nerve roots, you start thinking TOS. So by itself, dorsal scapular neuropathy, because it's a small peripheral nerve, it would tend to be a different picture, but your doc has to be thinking about it and looking at it specifically. Thank you for the question. That's a good one.
Yeah. And I would also say that there are, here's a new one.
Hi, Nick, Dr. Nick, I'm going to call him. What percentage of Peck Minor syndrome patients have a double crush from scalene compression? Okay, so this is a well-trained chiropractor who knows a lot about TOS and sees patients with this and other neuropathies. And the complexity of the question shows that. So first of all, I'm going to get a little soapbox here. Peck Minor syndrome is something that I believe is misunderstood, certainly not fully understood. Some of the bigger names that publish on this, they say there's a space behind the pec minor muscle, the retropectoralis space, and that's just another spot where the plexus gets compressed. I can tell you from, number one, my experience, which is not small, and from the literature, there is very little, if any, evidence to support that. The space behind this muscle actually is bigger in patients with TOS than in normal asymptomatic patients. Without boring you with all the details, what I believe happens is one of two things. The pec minor muscle gets too tight and it changes the position of the scapula, the shoulder blade, as Dr. Jenkins mentioned before. That muscle will pull things down your chest and it'll pull the collarbone secondarily closer to the first rib and cause compression. But the other thing is that the space, the retropectoralis space, is actually an inverted triangle. So when you raise your arms or reach in front of you even, the nerve bundle, the neurovascular bundle, slides up into the wider part. Now at the top of that wider part is a bone called the coracoid process. And in some cases that I see, the plexus is pulled under that, what we would call bowstringing. If that's the coracoid process, the nerve kind of pulls up like that. And so there can be tension. And there's a clinical test called an upper limb neural tension test, where you measure things like compression and tension on these nerves. They have to be able to glide. They can't be under tension like that without causing symptoms. So first of all, Peck Minor syndrome, in my eyes, is misunderstood. I think it is real. I can tell you that 1950, Jerry Lord did the first pectoralis minor tenotomy where he released it and patients did well. The reason why they did well is not clearly shown. It's certainly a fertile place for investigation. But since at least 1950, we've known that the pec minor is involved in this. It came into vogue about 10, 12 years ago, and now some docs will do pec minor tenotomies because it's a very minor surgery. But I think we need to assess it with caution. I'll say one more thing here, double crush syndrome. We should talk about that, but I'm going to give the ball to Art because this is also in his bailiwick.
Yeah, so I would say it's that I almost want to turn this question on its head and say, well, what percentage of patients just have pectoralis minor syndrome? It's a very small percentage. It's profoundly, and by pectoralis minor syndrome, I talk about, my examination is geared 100% towards what Scott was describing, the bowstringing that occurs, and is this patient a target for a release of the pec minor, because that's where they're getting their symptoms from, in a position where the pectoralis minor muscle is causing them some bowstringing. And that's due to, I think one of the things that I've seen on some of the different studies is that the shoulder dynamic is so off that the shoulder is actually a little bit out, and that causes the nerves and the neurovascular bundle going around that coracoid process to actually be kinking at a really much sharper angle than the nerves like to be drawn at, just because it's so shifted in its position. I often see patients with TOS who I can elicit some degree of pec minor tension, but I think it's back to the point of it is more of a double crush, and that the primary problem is the proximal area. The tension in this area is a secondary issue. And so for most of those patients, I don't do, even if I elicit the tension, if they also have another problem, we release this, they feel better, and they don't need to have a separate tenotomy done. And so I think the answer really is, what depends on what you call a pec minor syndrome. If it's truly isolated pec minor, then the answer is no. If it's pec minor in the setting of scalene, costoclavicular, or in some cases even cervical rib etiology, then yes, we see it quite frequently, that they have symptoms in the pec minor of pec minor tension, but not that it's a separate entity that requires separate treatment. So, in general.
And for those viewers who are not doctors, when you compress the nerves proximally, they can get more sensitive everywhere distally to even normal degrees of compression. So it looks like they have a distal neuropathy, but as Art is saying, if you treat it proximally, all that may go away. Am I putting words in your mouth, or do I have it fairly correct?
No. In general, we treat the proximal problem first, and more often than not, it makes them better, or sometimes even makes them go away completely. So, yeah.
Thank you, Nick, for the good question. Appreciate that. Hi, Samantha. Thank you both for offering all your expertise. Will patients with neurogenic TOS exhibit color and temperature changes in the hand and arm? That's a good one.
So the short answer is not usually. And the long answer is if they've developed this complex regional pain syndrome, if they have developed a chronic irritation that involves the sympathetic nervous system, you can get something like that. But more often than not, it's either a vascular A or V TOS, or it may be actually a sympathetic dysfunction, and it may involve whether it be hyperhidrosis or other symptoms that involve inappropriate sympathetic stimulation. So or you can have both. So we like to call it.
What's the idiopathic syndrome where the hand changes color, pallor, cyanosis, rubor? What's that called again? I'm blanking.
Well, I mean, we talk about,
I'm sorry, I'm interrupting.
Corners and other sympathetic dysfunction, but there's but anyway.
So I'm going to show you my geekiness with TOS. Władysław Ellis is a neurologist he's now in Grass Valley, California. Really bright guy. His daughter is a really good neurologist in Berkeley, Selena Ellis, one of the people we recommend. Anyway, he did a paper UCSF in the 70s with Ron Stoney and another doc whose name I'm blanking on, but they actually did thermography. They would measure the temperature of the hands while they were doing surgery, and they found a few things would actually increase the temperature in the hands. So what Art is saying is true. There's evidence that in a small percentage of patients, they do have sympathetic involvement. Sympathetic, parasympathetic are branches of the autonomic nervous system. It's an unconscious nervous system. It regulates blood pressure, the temperature, hyperhidrosis, sweating. And there's a paper from the early 1900s that showed that a small percentage of patients actually had in their C8 and T1 nerve roots, the sympathetics were distributed unevenly off to the side and back where they could be pressed upon by cervical ribs. It's from like 1910. So in some patients, there's evidence that, yes, they do get this kind of phenomenon, color and temperature changes, and there's some evidence supporting that, which I just said twice, I think. So thank you for a cool question. Hi, Anna. Anna again. Can mild scoliosis in the cervical and thoracic spine cause more pain and problems when you have been diagnosed with neurogenic and venous TOS? I think the degree matters here. When you get scoliosis, as you know, this is something Art deals with all the time. As a radiologist, though, I'll just tell you, we see varying degrees of narrowing of the central canal or neural foramina. Those are the side holes. And so depending on the location, the cause, whether you have vertebral anomalies, there's a whole lot of ifs in this as to whether nerves are compressed. And then there are also postural changes, which means that the shoulders may then be unbalanced. And at this point, I'm going to kick it over to Art for more knowledgeable expertise.
Well, I'm going to echo what you said. It's a question of degrees. Obviously, as the spine curves, the shoulders compensate as well. Scoliosis causes significant deformities in the way the ribs develop. And in fact, actually treating scoliosis can make the rib hump gradually get better on its own once you straighten the spine. And so the position of, and as we've been describing, the position of the scapula is central to the pathology of TOS, and specifically NTOS. So yes, it can, and obviously the degree of scoliosis will be one of the contributing factors to the degree of symptoms and the degree of worsening in your symptoms if you have both TOS and scoliosis.
Thank you. And Anna, thank you for the question. Herb, do we have any other questions at this point? I know we're running short in time here. All right. So first of all, Art Jenkins, Dr. Jenkins, thank you so much for your expertise and your time. I know a lot of TOS patients who really appreciate your expertise.
I do my best.
And your best is really good. I'm Dr. Scott Worden, the TOS guy. We love doing these educational things. Please visit toseducation.org, who does all this educational stuff, help us on social media, spread the word for those patients who haven't found TOS or haven't found, even if they do have TOS, how to get help. So pay it forward. You can reach me through tosmri.com. We're glad to answer any questions. If you want to be connected with Dr. Jenkins, we are more than happy to do that. He's an excellent source of expert advice on TOS. Thank you for the excellent questions. We're so glad that people attended and bring these good questions up. Nothing else to say. I know we have some holidays coming up, but we've got some more educational events, as we see here. On November 8th, which is a couple weeks from now, we have how to select the best thoracic outlet syndrome specialist. All right. So again, thank you very much. And Art, we'll talk to you soon.
All right. Thanks, everybody. And Scott, thank you as always for putting this together. You run a great show.
Thank you.